So I'll be presenting a case where we have done a TAVI via calcified artery. So my patient profile begins with a 72-year-old female with a history of GBS, bilateral lower limb weakness, and presented in NYHA class 3. The comorbidities were hypertension, and this patient had calcified severe aortic stenosis with mean and peak gradient of 30 and 50 mmHg, moderate AR, moderate MR, no RWMA, and LVF of 50%. So with the high STS score, we went with TAVI protocol and CT aortogram was done, where we could see that the aortic valve was tricuspid and had moderate aortic valve calcification. The LVOT was similar to the annulus area, and the area was around 22, similar to the LVOT. The coronary heights were optimal, 15 and 11, and also that mild calcifications were noted at sinotubular junction, arch of aorta, and descending. The sinus of Valsalva was roomy. So further CT analysis was done. Then we come for the iliofemoral analysis. And here we could see that there was severe abdominal aorta calcification, with severe calcification which was observed at the both common iliac arteries. So the area, the size of the arteries, everywhere around, the maximum was 5.3. So we also saw the alternate routes, and in that we could see carotid is still calcified, entry point, subclavian, a lot of angle, calcified at the entry point. So what do we do next? Whether we switch to subclavian, carotid, transcaval, transeptal, transapical, or we still go ahead and do the trident testal femorals. If yes, then what would be the mode of it? So we would go with the serial dilatation, opening it up with calcium modification techniques using IVL shockwave. So we went ahead with femoral access. So we did an ultrasound guided puncture. You can see here. Secondly, we went with intravascular lithotripsy shockwave of 6 into 60 mm, and we gave all 10 cycles of it. Following which we could see we navigated our sheath through it. The sheath with a gentle push could go ahead, but however there was a calcium chunk where it would go and stuck to. So we did get back our IVL, we did 1-2 cycles more, and then we placed it. Then the wiring was done, baseline angiogram was taken, and you could see that we also did a pre-dilatation with 18 into 40 mm atlas balloon. So this pre-dilatation, though we had a moderate calcification, was also done to see whether we could navigate through the aorta at all. Secondly, we did the positioning of the valve, and here the first slide you can see that the valve takes a lot of effort. With a gentle push, however, it could go ahead. Then we placed it, we deployed it, everything looks good. We came out, we closed the site, angiosil and ProGlide were used. Then we see a dissection. So the right femoral had been dissected. Initially, we did go ahead with the command wire. We tried to go retrogradely. The wire didn't cross. We put in a sheath in profunda just to have an access. However, eventually we could cross through the command wire from the retrograde from the other side. And then we pre-dilated it with 5 into 40 mm balloon, and then did a covered stent of 7 into 60 mm. And end results look good. So my take-home message would be, intravascular lithotripsy can safely facilitate the transfemoral TAVI in settings of severe iliofemoral calcification. The integration of shockwave into TAVI, it strategizes and allows selected high-risk patients to benefit from the transfemoral approach. And by overcoming this calcification, we could benefit the patient by minimal invasive transfemoral approach and avoided the high-risk alternative access route. And patient was discharged in hemodynamic stable condition, was doing well on follow-up. Thank you.